So welcome everyone. My name is Jani Ruotsalainen and not Jos Verbeek as it says on there on your screen. So no worries. There hasn't been a coup d'etat. I'm not trying to usurp our coordinating editor. I'm the managing editor of Cochrane Work. I'm the review group responsible for conducting and publishing Cochrane systematic reviews about occupational safety and health. And today we have our lovely editor Karen Nieuwenhuizen, who is a very experienced Cochrane review author and has been with our review group for several years now, helping many review teams to success. And she has a nice review about return to work of depressed workers, and she's going to tell you a lot more about the review and its results, and then we can discuss. The way this thing works is I will be recording, if I didn't mention that already, so there will be a video available after the event in case you or your colleagues want to revisit what we talked about. And you have the opportunity to ask questions either during the presentation or afterwards. Or if you don't feel like interrupting the flow, you seem like Karen's really getting into the thing, you can write down your questions in the chat window, and I will be managing the chat window, so I'll try and pick up your questions from there. And if anything's unclear, you have technical difficulties or whatever, then please just make some noise or submit a comment in the chat window. But other than that, I think we're ready to start rolling. Karen, floor is yours.
Okay, thank you, Jani, for your very nice introduction. Well, I'm very glad that Jani is going to be here and helping us with the moderation. Because I, of course, cannot see all of you, and while I'm presenting, I won't be able to see all your faces. So make some noise, chat to Jani, whatever you feel that is needed to make sure that I'm talking about the things you understand and are of your interest. First thing I'm going to do is to start my presentation now, and I hope you will be with me still.
Yes, looking good. Please go ahead.
Okay, I will go ahead. Well, Jani already introduced the subject we're going to talk about today, which is return to work in depressed workers. It's been, I call it my review, but of course it's our review. So there's a whole team of people who've been working with me on this subject, and they're all listed here. So just to make sure I'm not I acknowledge them sufficiently. But this is my first slide because I think it's very interesting for me to know what you are looking to hear from me today. So if there's anything you think you might want to learn today, just chat to Jani or talk to me directly. That's also fine by me. Everything's good. Okay, I'm going to start with the actual presentation.
Please do.
First of all, why the focus on depression? I think maybe for a lot of people who are with us today, it's not a big surprise, but depression is a very important topic. If you look at the global burden of disease, for instance, it's a major contributor, not only because a lot of people have a depressive disorder, and so it's a high prevalent disorder, but also if you want to have this disorder, it's associated with great suffering and even high mortality. So it's a subject that's been very of interest for researchers and policymakers alike. So why the focus on depression in relation to work? I think a lot of the impacts that depression has on work stems directly from the symptoms. The nature of depressive symptoms are very much interfering with work. So I've listed the two core symptoms here: depressed mood, decreased interest or pleasure in activities. I think you can imagine that if you're feeling these types of symptoms, it's very hard to go through your work day. And of course, then there's a loss of energy. Well, try getting up in the morning if you're depressed and go to work. Concentration problems. That's also very much a problem if you're interested, if you want to do your work good. Concentration is one of the key things you need to have. Then there's guilt, feelings of guilt and worthlessness, which can also be at the workplace if you're constantly thinking it's your fault things are not running as smoothly as they should, and you experience a lot of feelings about worthlessness about those problems. It's of course a big problem in the workplace. Well, this is one of the symptoms. It might not be too having not too many effects on work. Change in activity means not being able to sit still, or not being able to move as actively as you could earlier. So that's something that might be interfering with work. Of course, then sleep problems. That's also a big problem if you're wanting to go through your work week, feeling able to do your work. And then there's suicidality, which is of course a big problem. So these symptoms are very much impacting work disability. And if we look at the type of impacts, of course, absenteeism is very much affected by depressive disorders. A lot of absenteeism is caused by depressive disorders, and absenteeism is also the focus of our review. But in the last years, a lot of studies been coming out about lost productivity at work, or even job loss. And so it's even when you are at work, depression can still impact your ability to do your work properly. So that was our objective in our review, was to see what is known about what we can do about the impact of depression on work disability. So is everybody familiar with these types of reviews? Patient intervention, comparison, outcome, any? I'm just going to, no questions yet, Yanni?
None so far.
None so far, okay.
Yeah,
I'm just here. Going to assume here that I'm still making sense.
Yep.
Well, so what we looked at any study we could find which included depressed workers, looked at interventions at the workplace or worker directed, and I'm going to talk in detail about what that means later on in my presentation. But we only looked at randomized controlled trials, or cluster randomized controlled trials, and our primary outcome was days of sickness absence. We also looked at work functioning if it was available, but our main focus was days of sickness absence, because that's also the outcome that's where most studies are being conducted, although these types of studies are becoming more and more available in recent years. I think I hear some responses. No?
No, it's just
okay.
someone...
No, it's just a little noise. Okay.
Yeah, I'll try and get rid of it.
Oh, it doesn't affect me, but just shout out if there's any questions. So if you want to impact, or want to reduce the impact depression has on work disability, there's basically two approaches. First, you could try and focus on direct your intervention towards the worker, which means you reduce the symptoms, or you could try to focus more on the work consequences of the symptoms of depression. And I'll go into a little bit more detail. First, the worker directed interventions.
Sorry, Karen, question
yes.
I have. Can you go back to the previous slide? So none of the interventions were directed at work or causes at work? Or is that too difficult or too broad?
Well, it's usually in return to work studies, people or absenteeism studies, the depression was already present. So it's
Right.
Studies looking at those causes usually look at prevention of depression. Mm-hmm. But if you will look into work adaptations, I think it's logical, although it's not completely registered in those or stated in those types of studies. It's only logical to look at the causes of depression as sort of the ideas what needs to be adapted in order to return to work, for instance. So
quite right.
There might be a little bit in here, but it's not completely directed at causes.
Nice. Please
Is that an answer to your question?
Yes,
okay.
Indeed.
Okay. Right. So worker-directed interventions have the rationale that if you reduce the symptoms of depression by just clinical treatments, you also reduce the impact those symptoms have on work outcomes. And there's basically there's a few approaches. For instance, of course, there's antidepressants and medication, psychotherapy or other psychological interventions are those types of are included as worker-directed interventions. Oh no, sorry. And over the last few years, interventions having to do with exercise as a way to reduce symptoms of depression have been evaluated more and more. Of course, there's a lot of literature around on the clinical effectiveness of these types of interventions. But if you want to see studies that evaluated work outcomes of these types of interventions, in 2014, there were only 18. And 6 looked at medication. There were 6 with psychological interventions, 4 with combining those two, and 2 studies on exercise as a way to reduce work disability in depressed workers. So first, some words on the antidepressant treatment as a way to reduce work disability. We found 5 studies, it was 6 in total, but 5 are listed here. And I'm not sure if everybody is familiar with these types of figures, which are produced in systematic reviews. So I'm going to say a few words on it, but just let me know if anything's not completely clear. But without going into too much detail, the effects of several studies are combined in a figure like this, and this is the estimate effect, and this is a confidence interval. So what it says here is if there's the whole line, the whole confidence interval of a certain comparison is completely on the left or completely on the right side of the 0, it means that there's a statistically significant effect of one intervention, of the intervention or the control. So in this case, any line on the left side of the 0 would mean that there's a significant effect of the SSRI. That means it's a certain antidepressant medication. It's selective serotonin reuptake inhibitors. And these were compared to a different brand of antidepressant, the noradrenaline reuptake inhibitors, or the tricyclic, which is a bit older medication, or another type of SSRI. So, and what we see here is that it's really, there's no clear picture to be seen in this in the outcome of these studies. So if we look at sickness absence, there's really no clear view on whether it's effective to use SSRI versus other types of treatments. Of course, these are only the yes.
Question.
Yes.
Can you explain why this particular forest plot doesn't have a summary diamond that would pull all results together?
Yeah, because they were too. There was some statistical heterogeneity. Oh, you let me pronounce that word. It's very hard. So they were too dissimilar to pool, basically. So we decided not to pool because of that.
Quite right. Yes, yes, okay. I would have said the same. Yeah, as you can see, some of the confidence intervals don't overlap, so they're clearly quite different. Yes.
Thank you. Yes.
Please continue.
Yes, and so our this is our conclusion in the review was that it's highly inconsistent results, and of course this is only a small portion of all the sort of knowledge on antidepressants treatment that's out there, but just they just don't include work outcomes as much as you would expect. So what we know about work and about absenteeism is highly inconsistent. So that's why it's so, for us, it was strange, or Jos Verbeek also works as an occupational physician in Finland. And he was sent a letter by a pharmaceutical company that said, well, that their specific brand of antidepressant was very good if you wanted to help people return to work. So that was their statement to all occupational physicians in Finland, as I understood from Jos. So he, at the time, it was the 2008 version of our review, but he sent an angry letter to the company saying, well, you cannot say that because there's no substantiation for it, and they had to send this apology letter to all the occupational physicians. And I'm hoping Jani, I hope this is the right letter because it's in Finnish, and but Jos told me this is the letter they had to send. Yes. It's the correct one. Yes, it's still in Finnish, so I have to trust you there. But translated, it's they had to say, well, that there's no depression treatment among which their own type of medication that was shown to directly influence the shortening of sick leave, and they had to refer to our review at the time. So, well, it was one of the good things about doing a Cochrane review, that sometimes you get to change the world just one little tiny bit for the good. So we need to, even though the answer to the question, does medication work? We don't know yet. There's no one medication being better for return to work than another one. So that has to be our conclusion, and is still our conclusion now, I would say. So if it's not medication, what does seem to work for return to work? Well, we also know a little bit more about what also does not seem to help people return to work, and that is if you do care enhancement in primary care. And I'm not sure if everybody's familiar with those types of programs, so I'm going to talk a little bit about it. It's where primary care offices are they are trained in clinical guidelines, where, for instance, there's help of installed in with sort of the treatment guidelines are more evaluated in patients. So physicians are helped to be able to do the correct treatment as advocated in the guidelines, because if there is, for instance, pop-ups on their computer while they're treating patients, these types of things. So just trying to optimize the clinical care provided in primary care. And there's been 3 studies conducted on that. But this is our conclusion. It was a total of low quality evidence of no effect of enhanced primary care. So if you want to enhance return to work, this is probably not the way to go as well.
Okay. Someone finds it funny. That's nice.
Oh well.
Should we ask everyone else at this point?
I'm curious.
Anyone have any questions at this point, or want to share their joke?
Okay.
I'll just mute everyone, and we continue. Here we go.
I'm muted, which is good during this seminar.
Sorry.
Thank you. So yeah, if you want to reduce symptoms, there's also a thing we're not that sure about. So that's the exercise and enhancing return to work or reducing sick leave. There were only 2 studies which evaluated the effect of exercise on this outcome, on return to work, and it had multiple study arms, one of the studies. So what we were able to find is that, or conclude, was that there's low quality evidence, so we're not really sure, but there is some little evidence that strength exercises, so that would mean weightlifting in a gym, for instance, is better than relaxation. If you want to enhance return to work, well, I'm not sure if that's good news for people around, but because relaxation sounds nice, but if you want to return to work, it's probably not that effective. And then there's moderate quality evidence that aerobic, so that's any of those exercises you have to breathe very quickly. Running, running therapy is of course an aerobic exercise therapy. But that was found not to be more effective in returning to work compared to relaxation or stretching. So those were sort of placebo interventions in those studies. So, well, the evidence is, there's some evidence out there, but we're not really sure about the exercise in enhancing return to work, I would say. Well, and then there's good news. There's actually good news about clinical interventions. We did find that there's one specific type of program which might be effective. That's online or telephone cognitive behavioral therapy compared to, well, regular primary care here. And there were 3 studies who looked at these types of programs. One very small study with a very large confidence interval, and 2 larger studies. But what they did was that they had structured sessions, 8 to 10, in which cognitive behavioral therapy was provided. But it all had a therapist or a physician at the receiving end of the intervention. So it would not be a person doing a computer intervention on their own and never receiving any feedback. There would be an involved therapist or physician who would feedback on the therapy as it went along. And that did seem to work, because here we were able to make a summary of the results. And it's very small here in the letter, so I've got In the next slide, I have some the numbers, but we concluded that there's moderate quality evidence for these types of interventions being better than regular care. So this was the effect size, but I think it's also very interesting to look at the actual absolute differences between two in the comparisons. And because we're looking at days of sick leave, this is how you look at the outcome. It was either half a day less absenteeism in 4 weeks, or 7 days in 8 months, and another study which had 5 days less sickness absence in 8 months. So I think the clinical or practical relevance of these types of outcomes is, of course, something as a reviewer you don't decide upon. It's the people in practice who have to decide this is worth our efforts and maybe also our money. Right, and also some more good news on the worker-directed intervention is that there's also been a bit of a different approach, which was telephone outreach and care management. It was one study, but it was a very large and also high-quality study. So we did found it to be important. In this type of study, they facilitated access to care. So workers who had a depression were helped find a psychotherapist, or help bypass any waiting list for psychotherapy, for instance. They were also supported in their treatment adherence, whether it's appointments with psychologists or whether it's medication schemes. And if a worker could not find a psychotherapist or didn't want to go to the psychotherapist, they were provided with telephone psychotherapy. So a bit like in the intervention we just had a look at. And of course, it's one study, but it's very clear that it's more effective compared to care as usual, which was basically, access to primary care, but not they were not prohibited to do any interventions in the other groups, but they were also not encouraged to do any intervention. And what we concluded was that there's high quality evidence that this approach is effective in enhancing return to work, or reducing sickness absence, I should say. But the absolute difference, and again, it's up to you if you find it relevant enough, was 2 weeks in a year, the difference between the intervention and control group. Right, so that's what the review showed about worker-directed interventions for depressed workers. So I think this would be a very good time to hear if there's any questions or thoughts about this before I go into the other type of interventions.
No one's burning up with the questions so far. Let me check the chat window. Nothing there. Okay, maybe we save questions and discussion for the end.
Right.
Okay. Yep. Please go on.
Yeah, people can hear me. Okay.
Yep.
So now to the other approach, which can be taken if you want to reduce sick leave in depressed workers. It's looking at the work-directed interventions. We found 5 of those in our review. 3 added specific work focus to a clinical intervention. 1 compared 2 different types of work-directed interventions. And 1 added a clinical intervention to work-directed intervention. And I can be, if you want to know more details, you can always email me or ask questions afterwards, but these interventions were not effective. So I'm going to, I'm going to focus on these types of interventions and tell you a bit more about what they and what these types of interventions did. These interventions were interventions we called modified work and supportive interventions. It's a bit of a broad term, so feel free to ask any questions about this. There were 2 studies coming from an occupational therapy perspective, and one coming from a employee assistance program perspective. But if you look at the details of what these interventions were doing, there's a lot of similarities. So we felt that they could be combined into one program, one comparison in our review. These 2 studies were about adding an occupational therapy program to a very clinical program in an academic outpatient center. So there's this elaborate clinical program for depressed people, and they added this program with the occupational therapist contacting, well, it was in the Netherlands, so they contacted occupational physicians. They also, if the worker was willing, contacted the employer. And together with the worker, they explored all of the work problems which were present and tried to come up with solutions to those problems, either with the worker, but also in those talks with the physician and the employer. And also they looked at work reintegration. They had a gradual return to work program in place in which they did the reintegration in small steps and evaluated the effects of those steps. So that was the occupational therapy. In the employee assistance program, they did something which was pretty much similar. They did work coaching and work modification. So if there's there's a work problem that you encounter, you try to find solutions for those types of problems in the workplace. So it was not in the review of in the study, but an example of such an intervention could be if you're having a hard time concentrating due to your depression. It's also you could be you could have a different room in which there's not a lot of colleagues, in which you can concentrate better. There's not so much noise. So these are types of modifications which might be feasible for depressed workers. Also, timing can be a modification you can do to the work. Work time arrangement, because we do know that depressed workers usually have a hard time in the morning. The symptoms are worse in the morning, and if you can arrange to start later with your workday, it's also a type of modification you might do during the return to work process, which might help. So these are just a few of the examples I came up with, but just to give you an idea of what modification can mean. Of course, there was also a clinical part of the intervention, and this it meant care coordination between providers. That's because usually in depressed workers there's more than one care provider involved, and then cognitive behavioral strategies being provided through the counseling. So again, cognitive behavioral therapy. If we look at the effects those studies had on absenteeism, well, we looked at the combined the sub effect of occupational therapy alone, which is, well, it's almost shows that it favors that intervention compared to clinical interventions alone, but well, it's it's almost completely to the left of the zero. The employee assistance program was more clearly on the left side of the zero. But if you look at the combined effect, you see that adding a work-focused treatment to a clinical treatment is more effective than clinical treatment alone. And the level of evidence was moderate quality evidence. Again, I feel obliged to show you the actual number of days in absolute differences. Well, one study had a very small absolute difference, I would say, half a day in a year. Not sure if that's where all the trouble, but the other had 17 days in half a year, and another one 2.5 days in 2 weeks. So that those are more substantial. Right. Almost scared to ask, but are there any questions or remarks about this part of the presentation? Because this is the work-directed interventions for depressed workers part of our review.
If anyone's brave enough to
I'm sorry for my late question.
Yeah.
Hello?
Hello.
Hear me? Yes. Hello. I have a question. It's a little bit late for the CBT, for the online or telephone CBT. Can you say a little bit more about this, the structure of this?
So you're asking me about the CBT, what these sessions entailed exactly, or?
Yes. Yes.
Yeah. Well, there were. It's kind of hard to know all the details of the intervention because we have to deal with what's in the papers, and we also contacted authors if there's anything unclear. Okay. In the review we have I'm not sure if you're familiar with the Cochrane reviews, but we have the table of included characteristics of included studies. And everything we know about intervention is listed. It's listed there. By heart, I would. Yeah, I'm not sure if they. I'm not sure if there's any specific details you'd be interested to know on the cognitive behavioral therapy. I don't recall any really much detail, but. Is there anything you'd be interested in?
Have to contact the author. Okay.
Yeah, and also in the review there's information about the number of sessions. I'm pretty sure. I'm not sure if the topics of the sessions are also listed there. I would need to look that up. You can either email me or look at the review for that, and of course contact the authors. Yes.
Okay. Yeah. Thank you.
Thank you.
Like Karen said, we usually, when doing Cochrane reviews, we have to rely very much on what the authors of studies actually report about their studies, and especially when it comes to interventions and the details of the interventions. What did the authors do in what order and what magnitude and what duration? These details are very seldomly reported in much detail. So you often have to contact the authors and ask for more details. And but thankfully nowadays there's very good reporting guidelines. For example, what is called the tidier checklist that helps authors of at least new studies to know what to report and in what sort of detail, so that it's helpful for people doing reviews and for people who are trying to replicate those interventions or implement them in practice. So yeah, that's a very good question. So we can move on, I think.
Yes, it's for me, right? There's a cue.
That's cue for you, yes.
That's a cue for me. Okay. Well, I don't want to, I'm a happy reviewer, but we all know that Cochrane reviews are a lot of work and they need to be updated. And even our 2014 review needs to be updated very soon now. I'm aware of. But I remember in 2008 we did a lot of work, and sort of the conclusions we came up with was that at that time there was a lack of work focus in interventions for workers with depressed workers, so we were unable to say anything about work-directed interventions. And for the worker-directed interventions, we found that we couldn't find any evidence of one clinical intervention being better than another one. So after doing all the work for the update in 2014, we were sort of happy to be able to report some recommendations. So, you know, the knowledge has been growing. So I would say, and although, you know, in Cochrane reviews, you're not supposed to be to make a lot of recommendations. You need to sort of objectively state what you found. But I'm in these types of webinars, I get to just say a little bit more about it. And I would say, if you aim for a reduction of sick leave, what the evidence tells us at this stage is that it's important to add work-directed interventions to clinical interventions. And if you're doing a clinical intervention, it's you have to consider enhancing standard care, occupational or primary, with structured online or telephone cognitive behavioral therapy, or one of those also structured telephone outreach programs. I would say that's the knowledge that is out there at this time. Although, you know, the update might show some new results, so we'd have to see that in, say, a year or so. Right. So that's pretty much the overview of the results of the review we did. There's, of course, also a lot to be said about the whole methods section of it, and I would love to go into detail about it as well, but it's mostly can be very technical and boring, so I kept it out of this presentation. But you know, if there's any questions about that, I'm also happy to answer them as far as I can do it from here. So thank you.
Yeah, thank you very much.
Thank you all for participating. Feel free to ask any more questions now or later. Like I said in the beginning, I have recorded the whole event, so there will be a video version available in some weeks' time when I manage to edit this into a presentable format. But if there aren't any more questions at this time, we say thank you very much, and hope to see you back in the next webinar.
Yeah, bye.
Thank you very much.
Thank you.
Thank you. Bye-bye. Thank you.
Bye.